Hi, my name's Stuart Phillips. I'm a professor in the Department of Kinesiology and a Tier 1 Canada Research Chair at McMaster University. Today I'm going to be speaking to you about the critical role of protein in mobility in the prevention of muscle loss in aging and illness. The learning objectives of this webinar, at the conclusion, you should be able to understand the mechanisms that underpin muscle protein turnover and the critical roles of protein ingestion and activity. You should also be able to understand the role of protein in muscle loss and inactivity during illness, and particularly so in the elderly. You should be able to understand the key roles of the amino acid leucine and the role the protein source or quality play in muscle protein turnover. One of the questions we want to answer is, why is muscle important? First of all, every older person experiences a sarcopenia of aging. That's the gradual age-related loss of muscle mass and function. Muscle is also the single largest site of blood glucose disposal after ingestion of a meal. It's the largest bodily reserve of amino acids. It has an obvious role in locomotion, and its preservation is predictive of survival, particularly in situations such as critical illness. When we talk about protein turnover, the easiest analogy I can give you is to say that muscle is like a brick wall. There are bricks going into the wall and bricks being taken out. Quite simply, if the rate at which bricks are being put into the wall is greater than the rate at which bricks are being taken out, then the wall is going to grow. If the opposite is true, or bricks are being taken out faster than they are being put in, then the wall is going to get smaller. Clearly, in situations of critical illness or stays in the intensive care unit, then we're talking about the rate that muscle protein breakdown, or the bricks coming out of the wall, is going to exceed the rate at which bricks are being put into the wall. This figure highlights schematically the fluctuation in rates of muscle protein synthesis and muscle protein breakdown in a normal person when they're consuming 3 protein-containing meals per day. This could be breakfast, lunch, and dinner. What you can immediately see is that the rates of muscle protein synthesis fluctuate quite widely. In other words, every time a protein-containing meal is consumed, there's a rise in muscle protein synthesis to the extent that it's greater than muscle protein breakdown, and we get an area of green, which represents a net accretion of muscle proteins. However, muscle protein synthesis does not stay stimulated for too long and eventually declines until the subsequent protein-containing meal is consumed. In between that time, there's an area that you can see that's demarked by the gray area on this slide, which represents an area of muscle protein loss that's almost equal in magnitude to what we see during the fed state. There's a fluctuation between the rates of muscle protein synthesis and breakdown, and you can see that throughout the day, these are effectively balanced. The situation is a little different, however, with an increased loading stimulus or exercise. In this situation, we can see that the variation in protein synthesis is much greater. In other words, we get a much greater excursion or stimulation of protein synthesis, and we get a much smaller suppression in the fasted state. It doesn't take too much to recognize that each time now you're consuming a protein-containing meal, that you get a greater accretion of net muscle protein. The question then is, what happens with aging? Why is it that older individuals lose muscle mass? There are probably a number of events that contribute to an age-related decline in muscle mass that proceeds at a rate of about 1% per year, and muscle strength and power, which proceed at much faster rates, somewhere between 3 to 5% per year. We're unsure when this process begins, but it's measurable in most people in this 6th decade of life, or sometime in their 50s. The things that contribute to sarcopenia could vary anywhere from hormonal to vascular to something known as activation of satellite cells. We may not have too much control over these variables. However, we do have control over 2 variables which are particularly potent in stimulating muscle protein synthesis and helping alleviate or mitigate the decline in muscle mass. The first is exercise, and the second is nutrition. The focus then is on combating what we refer to as a condition in older people known as anabolic resistance. This slide shows the impact of protein feeding on a per meal basis on the stimulation of muscle protein synthesis. On the left-hand side, we have younger individuals, and on the right-hand side, we have older individuals. what you can immediately see is that on a per meal basis, or grams per kilogram per feeding or meal, that younger people require only 0.25 grams of protein per kilogram, versus older people on the right-hand side requiring 0.4 grams of protein per kilogram to maximally or optimally stimulate muscle protein synthesis to about the same level. If we add a 95% confidence interval, you can see that it could be as high as 0.3 grams for younger individuals on the left, or maybe as high as 0.57 grams for older individuals on the right. The same principle applies to older men as it does for older women. This gives us some insight into the effect that we call the anabolic resistance of aging. So this situation then would highlight that it's problematic in older individuals to consume protein in the fashion in which most people consume it, that is, in a skewed fashion. In other words, a small amount of protein at breakfast, a moderate amount at lunch, but a large amount of protein with the dinner time or evening meal. Quite simply, the small protein at breakfast and lunch does not effectively or optimally stimulate muscle protein synthesis, but the amount of protein in the dinner time meal might be well beyond what is needed and simply saturates the process of protein synthesis. The per meal dose of 0.4 grams per kilo will be what we were aiming for. So a recommendation might be that for older people, they should redistribute some of their protein from the later meal to the earlier meals in the day and perhaps focus on consuming a more balanced intake of about 0.4 grams per kilo per meal. In this situation, we would get a more even distribution of protein and a more balanced distribution of muscle protein synthesis, and then we would alleviate the age-related decline in muscle protein synthesis that we can see, or this anabolic resistance of aging. The question I think that's important to consider is what happens with muscle disuse. This could be in a situation of immobilization or a situation clinically of bed rest. Immobilization has been used as a local model of simulating what happens in muscle disuse, or even, as I'll tell you a little bit later in the presentation, in a situation of inactivity. This is a figure from a paper by Elisa Glover, published in 2008, showing that 2 weeks of immobilization of a single limb using a knee brace method resulted in a rate of muscle protein synthesis that was almost cut in half compared to a non-immobilized limb. This was in younger individuals. Interestingly enough, the rate of postprandial muscle protein synthesis, or with protein feeding, was also diminished. So what you can see in these situations is that immobility results in a situation much like we've seen in older individuals, essentially recapitulates the anabolic resistance associated with aging. This might raise the question of whether in aging it's a reduction in mobility that is partially or maybe even completely responsible for the reduction in protein synthesis seen on a per meal basis. So what we can say is that sarcopenia in older people would be accelerated or punctuated by periods of disuse. I've shown you two scenarios here. It could be something such as a knee replacement surgery or definitely bed rest. And in this situation, what we hypothesize would happen would be that the rate of muscle protein synthesis would be transiently accelerated, and you would get somebody who, with repeated episodes of disuse or hospitalization or just low levels of physical activity, would have a diminished muscle mass because of their inability to mount a full and robust protein synthetic response on ingestion of protein. Does it really have to be bed rest, though? Is it really a situation where we need to induce complete disuse in a muscle to see a change such that we see with immobilization? This is a figure from a study published by Chris McGlory and Tanner Stokes in 2018 showing that the reduction in daily step count from an average of about 8,000 steps per day to less than 2,000 steps per day in older people results in a pronounced reduction in muscle protein synthesis also. You might imagine that 2,000 steps per day is not much, but I think that it's important to consider that a hospitalized patient would probably take only around 700 steps per day. This figure shows you the rates of muscle protein synthesis that are integrated across the entire period prior to step reduction, indicated by the BL or baseline, during step reduction, and then in 2 weeks of recovery in both older men and older women. What you can immediately see is that step reduction results in a reduction in muscle protein synthesis that, interestingly enough, and much to our surprise, did not recover with 2 weeks of return to normal mobility. Thus, it may be that it doesn't have to be complete muscle disuse. It has to be a situation of reduced activity only that is responsible for the decline in muscle protein synthesis. You could imagine in older people, something like this might happen more and more frequently the older they get. The takeaway messages from this portion of the talk are that the dose of protein that maximally stimulates muscle protein synthesis in younger men following loading is around 20 grams, or about a 0.25 gram of protein per kilogram per meal, whereas the dose of protein that maximally stimulates muscle protein synthesis in older men is almost twice that, or around 40 grams or 0.4 grams of protein per kilogram per meal. These two numbers quite aptly illustrate the impact that age has on what we call anabolic resistance. This anabolic resistance is also related to immobility, and we can induce this in younger people simply by putting a brace or a cast on their leg. I hasten to add that we've subsequently followed these findings up and now see that the same situation happens in older women. Clinical scenarios that would also induce anabolic resistance would be something like bed rest. So the scenario is one where disuse or immobility, or possibly even a protracted period of inactivity, leads to loss of skeletal muscle mass that could be exacerbated by undernutrition or definitely by overt malnutrition. This would then contribute to an acceleration of sarcopenia, which indirectly then has an influence on what we call inactivity or disuse-induced muscle weakness. What then happens in the older patient that's in an intensive care unit? The theory is, or the data show, that the older intensive care patient is in a perfect storm for muscle loss. What we do know is that muscle wasting in the intensive care unit occurs early and very rapidly, and then reaches a nadir after only about 10 to 15 days. So it's important to realize that the intervention to prevent muscle loss in the intensive care unit should be directed at the early phases of the patient's stay. In this situation, the older patient would be on bed rest almost assuredly for the entire time that they're in the intensive care unit, unless they're receiving some type of rehabilitative therapy. They could be undergoing some sort of iatrogenic undernutrition because of the feeding protocols that are in place. Holding patients in an NPO situation would definitely be inadvisable. Protein feeding should begin as soon as possible. Whether that's parenteral or enteral is up to the choice of the physician. There would be procatabolic cytokines. There would be procatabolic hormones. There would be an anabolic resistance that is exacerbated in these patient groups, leading to a far greater loss of skeletal muscle. In this situation, then, sarcopenia is accelerated to a large degree, and we get the condition that's known as ICU-acquired muscle weakness that would be a precipitating factor for the development of frailty in older individuals. One of the questions that gets asked often is it just protein that matters, or is there a specific group of amino acids? The answer to this question is becoming more and more apparent, and the amino acid leucine, which is a branched-chain essential amino acid, stimulates a canonical pathway that works through something called mTOR. The mechanism for this has now been elucidated, and it's believed that leucine binds to a protein called cestrin-2 that is actually triggering a series of downstream events which result in essentially leucine turning on the process of muscle protein synthesis. This is a study by Tyler Churchward-Vinay, published in 2013. I'll just walk through this slowly because there's a few conditions here that are important to understand. The first is that the gray and the black bars represent a negative and a positive control. One is 6 grams of whey, one is 25 grams of whey. We've then got 2 additional groups in which the small dose of whey has added back to it 5 grams of crystalline leucine, or 5 grams of crystalline leucine, including the other 2 branched-chain amino acids, valine and isoleucine. What you can see here is that the rate of muscle protein synthesis is stimulated on the ingestion of all of these conditions between 0 and 1.5 hours. However, a further and continued stimulation of protein synthesis only occurs in the 25-gram whey dose or in the much smaller 6-gram of whey dose with the additional leucine. The small dose of whey protein you can see here is trending back towards baseline. And interestingly, the addition of the other two branched-chain amino acids, valine and isoleucine, probably act in some sort of competitive fashion with leucine to reduce the effectiveness of all three of those amino acids being delivered together. So it's really about leucine, which can make this smaller dose of whey protein look like a much larger dose, almost 4 times as large. We've actually observed the same effect in older women, as demonstrated by this study published by Michaela de Vries in 2018. What you can see here is that the addition of leucine, about 6.2 grams daily in a beverage that was administered to older women, resulted in an increased rate of muscle protein synthesis in the rested condition. Exercise helped this effect, but the leucine still further perpetuated the stimulation of muscle protein synthesis, and this was an integrated response over about 4 to 5 days. So quite simply, the higher the leucine content of the diet during this period, the greater the stimulation of muscle protein synthesis, and eventually we would hypothesize then the greater the retention of muscle mass, or in an exercise condition, the greater the gain in muscle mass. This is a figure from Bart Pennings, published in 2011, showing 3 conditions. Older individuals were given a dose of whey protein, indicated by the whey, a casein protein, indicated by CAS, or casein hydrolysate, indicated by CASH in this situation. The panel at left shows you the concentration of leucine that occurs after the ingestion of an equivalent amount of all of these proteins. And what you can immediately see is that the rise in leucine is most pronounced in the whey condition, is a little bit higher in the casein hydrolysate condition than the casein condition, but in all of these situations, it's the whey that results in the most rapid and greatest increase in blood leucine. And the panel then on the right-hand side of the slide shows you the resultant fractional synthetic rate, which is essentially an equivalent measure of muscle protein synthesis. As you can see quite clearly, it's the whey protein that stimulates the greatest rate of muscle protein synthesis, and this is despite the equivalent amount of nitrogen and protein in both the casein or the casein hydrolysate situations. This has led ourselves and several other researchers to propose a hypothesis known as the leucine trigger. In this situation, the levels of intracellular leucine need to rise in a muscle to a certain threshold, if you like. In other words, it's as if the leucine is acting to flip the switch and turn on muscle protein synthesis. So higher doses of protein, or doses of proteins that contain more leucine, would be more effective in stimulating muscle protein synthesis because they reach this trigger threshold, saturating the muscle protein synthetic response more efficiently than do lower doses or ingestion of proteins with lower leucine content. This figure is shown to remind you that not all proteins are created equal. This is a figure highlighting how different sources of protein contain differing amounts of leucine, and it's expressed as something called the leucine amino acid reference ratio. From left to right, you can see we have whey protein isolate, whey protein concentrate, 2 different versions of a soy protein isolate, SPI-A and B, a pea protein concentrate, a rice protein concentrate, and then a collagen hydrolysate. Quite simply, what the bars show you is that for each protein that isn't whey, you would have to consume, in the cases of soy or pea or rice, almost twice as much protein to reach the same amount of leucine, and in the case of collagen, between 4 to 5 times the amount, indicating that the quality of the protein would be an important factor in turning on the rates of muscle protein synthesis, and therefore in the preservation of muscle mass. It's important then to recognize that protein quality scoring methods that are indicated here by both FCAHS and FCAHS, FCAHS being the older of the two and the FCAHS being the more recent or more modern version, have various limiting amino acids. Nonetheless, whey protein isolates and concentrates stand above both soy, pea, and rice protein concentrates. Quite simply, the takeaway messages from this portion of the talk are that leucine is the key amino acid in the stimulation of muscle protein synthesis. Lower doses of protein can be made to be more anabolic with the addition of leucine, and the integration of higher leucine in a lower protein diet stimulates muscle protein synthesis in younger and older individuals. High-quality proteins with a high leucine content then would be a valuable tool and would be beneficial in the long run for the preservation of muscle mass and function. All of these messages would simply be amplified for older people, in which the role that protein quality plays in preservation of muscle mass is probably underappreciated, but should probably obtain an even greater consideration due to the anabolic resistance that we've already mentioned. If we're putting all of this together, we're talking about muscle loss in aging or illness that is common and can impact patient outcomes. Quite simply, older people probably experience more frequent bouts of inactivity due to hospitalization or illness or even convalescence from something as simple as the flu. And in these situations, it's important to try and support the patient with high-quality protein that would support increased rates of muscle protein synthesis. Muscle protein synthesis is stimulated by leucine in protein. It's the key amino acid. And loading or exercise enhances the effect of protein on muscle protein synthesis. It would be advisable for older people to avoid disuse or inactivity, or put into a clinical situation simply to mobilize patients as soon as and as often as is feasible, even in an intensive care setting where rehabilitation programs are likely to return a patient to health and allow them to survive the ICU, and definitely with increased survivorship, they would be able to even enjoy a better quality of life. If we increase the protein content of low protein containing meals, focusing specifically on the two meals that are probably lowest in protein per day, that is breakfast and lunch, particularly so in older people, and that higher quality leucine containing proteins like whey would be more effective than lower quality proteins in restoring lost muscle mass. Thank you very much for taking the time to listen and to watch this video.